Hello, everyone, and welcome to today's webinar hosted by ACRC Global. My name is Giselle Moriel, and I'm honored to be your host today alongside Shuko from our Tokyo team, who will also be assisting with hosting and translation.
おはようございます。本日はウェビナーにご参加いただきありがとうございます。ACRC グローバルがこちらのセミナーを主催させていただきまして、司会はジゼル・モリエルが担当させていただきます。私は東京チームになりまして、通訳を担当させていただきます。どうかよろしくお願いいたします。
We're thrilled to have Dr. John M. Norian with us to share insights on the latest advancements in fertility treatments and the path to success. Thank you all for joining us. We're excited for an informative and engaging session. And without further ado, we're going to go ahead and get started. Miracle Angels Reproductive Group is a subsidiary of ACRC Global, headquartered in California, USA. We specialize in assisted reproductive medicine for women, providing expert consulting services for egg and sperm donation, genetic testing, in vitro fertilization, and surrogacy in the United States. Our goal is to support couples and single mothers on their journey to parenthood. And now I'd like to introduce Dr. John M. Norian, a board-certified reproductive endocrinologist at HRC Fertility, the largest fertility program in the Western United States, with expertise in IVF, egg donation, and pre-implantation genetic testing. Dr. Norian has helped countless individuals and couples build their families. As a fellow of the American College of Obstetricians and Gynecologists, he is committed to patient-centered care and the latest advancements in reproductive medicine. And to kick off today's discussion, Dr. Norian will provide an overview of IVF and pre-implantation genetic testing, a crucial step in fertility treatments that enhances success rates.
Well, thank you so much for the introduction and a little bit of background about myself. I'm excited to be here today. And as a double board certified reproductive endocrinologist, I feel like I have a little bit of information to share, and hopefully you'll leave with more information today than you came with. Wonderful. So what is IVF and how does it all happen? So what in vitro fertilization is a technique that was developed, over 40 plus years ago, almost 45, 50 years ago. And this is where we learn techniques how to fertilize the egg on glass, in vitro fertilization. And what we do is we give medications to help mature and grow the resting follicles, the resting eggs. So we give medications, we give a patient their own hormones, their own pituitary hormones. We give follicle stimulating hormone, other hormones to help mature and grow the eggs. And then typically there are 4, maybe 5 ultrasounds. And we monitor a woman very closely, and we choose very specific protocols so that we can get the most number of healthy mature eggs that we can. And then after the follicles reach a certain stage, we go to egg retrieval, where a woman has a very light anesthetic, sort of like a twilight anesthetic, where her pain is controlled, but she's breathing on her own. We retrieve the eggs, and then we fertilize the eggs with the sperm of her choice, whether it's her husband, whether it's a donor, and we identify the best looking, best moving sperm, and we inseminate a single sperm directly into the egg as a way to help with fertilization. In our highly specialized laboratory, we grow or create these beautiful embryos. We grow them from 1 cell all the way to the blastocyst stage to about 128 plus or minus cells. And then what we do is when the embryo reaches this stage, that we can do additional screening. Now, the additional screening is where we can test the embryo. And what we do is we take 5, 6, 7 cells from the outside of the blastocyst, the outside of the embryo, the placenta portion, not the baby portion, and then we can do testing on it. Technique damages the embryo because when we have a quote-unquote normal embryo, the thaw survival rate is really high. It's greater than 95, 98% of the time the embryo should thaw well, and it just gives us more information. And specifically what it does is it tells us the chromosome number. So it essentially avoids us implanting an embryo with the wrong number of chromosomes, something like Down syndrome, Turner syndrome. We also learn if it's a male or female, boy or girl. So if you would like to know, and if we have the ability, then you would select which embryo to transfer. Remember that with IVF is we will give medications, like I said, to mature and grow the follicles. Now remember, not all the eggs that we retrieve mature, not all the mature eggs will fertilize normally. Believe it or not, and you see it on this slide, many women, especially when women are in their late 20s or their early 30s, will even think about freezing their eggs so that they can use them in the future if they need to, so they can help preserve their fertility. We grow or create these embryos from 1 cell to 120 plus cells at the blastocyst stage. So this is part of the reason why I think doing IVF here in America, and we'll talk about it towards the end, is because this is where the magic happens. And please understand, I have dear friends who are Japanese. Fertilizing and growing the fertilized egg or embryo to the full blastocyst stage, it takes really specialized laboratories. Not all the embryos that we create are going to be chromosomally normal. And this is seen as time goes on, as women as women get older, the percent normal per embryo declines. And when women are younger, the percent normal per embryo is higher. And when women are over 42, 43, we for sure still have pregnancies and live births, but oftentimes we have to work harder so that we can get better quality in chromosomally normal embryos. So that's a general overview of IVF. How does it happen? What we do is we stimulate the ovaries, we mature the eggs, we retrieve them, create embryos, and then we may or may not screen them using chromosome testing, PGT. So Japan is a wonderful country full of smart doctors, smart scientists. Absolutely. I, have traveled there before myself, and I respect Japanese physicians as well. Now, that being said, our program with HRC Fertility, it's more of a private practice program, but we're affiliated with the University of Southern California. The doctors at USC, the physicians in training work with us so that they can become more specialized, and they do a lot of research studies along with Caltech, the California Institute of Technology, which is very similar to MIT. The fellows are embedded in laboratories both at USC and at Caltech. So it allows us to be part of this real forward edge of medical and reproductive research, which is really fun. I love it. With PGT keeps getting more and more refined here in America, worldwide. And now what we're doing is we're screening the embryos with genetic sequencing and also using time-lapse video photography during embryo development, and even using artificial intelligence to help us better select the best of the best embryos, because I want to get as many and all of our patients pregnant as possible. So we're using this combination of reproductive biology with genetic testing, genetic screening to just try to improve safety and outcomes. The other neat thing about America is we have flexibility, we have creativity to just help people get to their final goal. And the final goal is adding to their families, right? That's why we're here. We're here for healthy live-born children, and they may need egg donation. Sometimes I help men for whatever weird reason, whether it's genetic, whether it's biologic, they don't produce sperm, so they need a sperm donor. Or lastly is the uterus, where women may have severe endometriosis. They may have fibroids. So we can be more flexible in the United States as we use surrogates to help people add to their family. The nice thing is also, just to mention, is we do high-level, high-touch care, meaning that you have a dedicated doctor, you have a dedicated nurse, dedicated financial coordinator here to walk with you as we go through the fertility journey or the fertility path.
Yes, well, thank you so much, Dr. Norian, for sharing your expertise in IVF, PGT, and fertility treatments. And now we've reached one of the most anticipated parts of the webinar, which is answering some of the most common questions that we receive. So let's get started. Is PGT-A mandatory for embryos used in surrogacy?
So the short answer is no, but yes, which I know is confusing. Because both the surrogate and our future parents, everyone wants to put our best foot forward so that we can have a healthy live birth and a good outcome. And I see PGT as a tool. It's a tool that just gives us more information, and it helps improve our implantation rates, pregnancy rates, especially when the source of the eggs is going to be greater than 33, 34, 35. Lastly, doctors like me are much more comfortable just transferring a single embryo, and that's where we have healthier babies, healthier outcomes. Because remember, babies do better if they grow one at a time. If we transfer 2 embryos or more, it's just higher risk for twins and for problems later on. So transferring a single PGT screened embryos, we have higher implantation, safer pregnancies, and we also learn if it's a boy or a girl in case you want to know that, but it's not required.
So moving on to our second question is, does the success rate decrease if embryos are frozen for a long time?
Essentially, embryos frozen do very well. They're frozen at minus 100 degrees over this, even at minus 100 degrees Celsius. And if they're stored properly, they should thaw well. Believe it or not, there was even a child born, I can't believe this, a couple years ago that was frozen as an embryo for over 27 years. Now, please understand, remember, embryos created a while ago, that those embryos maybe weren't the same quality as the embryos that were created in the last 5 years. Most of my patients will undergo frozen embryo transfer. Probably 98, 99% of my patients will undergo an embryo transfer with a frozen thawed embryo. And this is not only for the embryo, but it also adds safety because so women are using less hormones to prepare the lining and get it receptive and sticky and things like that.
When transporting frozen embryos internationally, is there a risk of embryo damage?
So long as you use a reliable, insured, well-regarded cryotransportation company, but remember, it needs to be coordinated in a very detailed way. When are we shipping the embryos? When are we receiving them? All these little small details matter, and this is what we do.
Does the implantation rate differ between creating embryos at a clinic in Japan and transporting them versus performing IVF and freezing embryos at a clinic in the United States?
So many clinics, as we talked about in Japan, are well regarded, well accredited, just like our laboratories in HRC Fertility in Pasadena. We are inspected regularly by the FDA, by the state, by all different public health groups in order to have the highest quality laboratory. But of course, if we create embryos in Japan, it involves more steps. It involves more steps that sometimes make things more difficult. And in our laboratory, what we really time everything based on a woman's menstrual cycle, her hormone levels, so that she can spend less time in America while she's here, but we still can create everything in our own laboratory. And believe it or not, we are based in Southern California, touring around Los Angeles, touring around California. Sometimes patients really enjoy it.
How many egg retrieval cycles are typically needed to obtain a normal embryo?
So more likely 2 or 3, depending on her response to medications. Remember, it does get more difficult to obtain a quote unquote normal embryo as time goes on. But that's where my compulsiveness about trying to optimize egg quality, optimize sperm quality, optimize embryo quality, using specialized protocols, I think helps to, create better embryos. But it is more challenging. And usually if we haven't retrieved a quote unquote normal embryo after 3 cycles, then we have to get more creative.
How many embryos or transfer attempts are typically needed to achieve a successful birth after transferring a PGTA-approved embryo?
So typically 1 or 2 cycles with high-grade embryos. And this is why we spend so much time focusing on our stimulation protocols, our preparation protocols, and all those small little micro details.
Now, when selecting a surrogate before medical screening, what criteria should be considered?
So when we're screening surrogates, firstly and importantly, we want her prior pregnancies to have been easy. I prefer that her prior pregnancies were all vaginal deliveries, but no more than 2 C-sections, and that can be very, very fine. In addition, I'm strict. I like a woman's BMI to be less than 30 and as metabolically as healthy as possible. Now, sometimes we have lovely surrogates who maybe their BMI is 31, 31.5, and if they just focus on eating more vegetables, getting more exercise, and they can get themselves different. So if a woman's BMI is, let's say, 31 or 31.5, if she focuses on her nutrition and her diet and gets herself to her pre-pregnancy weight for her other children, then I'm okay with that. Every patient is a little bit different, and you have to individualize. The other is, this isn't a key thing, is like I was talking about obesity and inflammation, I want her for her spouse to have a job and for her to live in an appropriate house or apartment or condominium so that she has less stress. So that's another key factor. And honestly, this is why I like working with ACRC, because ACRC gives me good, high quality surrogates and they live in a nice home environment. And that is why I think I have some of the highest successes in my practice and when I work with certain agencies like ACRC.
So even when transferring an embryo with excellent PGTA results, implantation and pregnancy may not occur. What is the most common reason for this?
There may be a uterine factor, right? There may be a woman who has uterine fibroids, may have endometriosis of the uterus, or for whatever reason doesn't develop a thick lining. So that's where we need to think about other factors that we can test for the endometrial lining, things like endometrial receptivity testing. So that's, those are factors that can come up. A uterine factor. Now, sometimes there are implantation failures. I need to be open about this, where even if we have a screened embryo that it doesn't implant, there are still limitations of PGT. It's a good screening tool, but we're not able to screen the entire human genome. Please remember, PGT has been through randomized clinical trials, but it's the best that we have to help us select the best embryos.
Does transferring multiple embryos to a surrogate increase the success rate?
Believe it or not, only a little bit. The biggest question is if there's going to be pregnancy or not. The biggest issue with transferring 2 embryos is the risk of twins, and then all the complications that come with twins: prematurity, brain hemorrhage, bowel problems, breathing problems. So babies do better, like I said before, if they grow one at a time. So that's why more and more throughout America, even with surrogacy, we're just transferring a single embryo.
Are there any recommended supplements to improve implantation rate?
I recommend all women to take a high quality prenatal vitamin that has at least 1,000 or 2,000 units of vitamin D3. In addition, I recommend that women do their best, take CoQ10, because more and more studies have shown that it slightly helps egg quality and, believe it or not, helps sperm quality. And if someone has PCOS, polycystic ovarian syndrome, I recommend women take Ovasitol or Myo and D-Chiroinositol because they help insulin work better, and insulin is an important growth factor.
I believe this is our last question, and it is, what is your favorite part of your job, Dr. Norian, and why do you love to work with ACRC Global?
So for me, I love the science and the biology of fertility care. I'm a nerd at heart, and I love the combination of medical procedures, steroid biology, and then genetics. I think it's such a neat interplay of human health. And I love also getting photos, Christmas cards of patients from around the world. It brings me joy. It brings me purpose. It makes me feel content that I've helped someone add to their family. It's cool. When it works, it's wonderful. And regarding ACRC, I know that I'm on a seminar with HCRC. I understand that. But I really have worked with them for years, even almost 10 years now. And I have always enjoyed the professionalism, the warmth, and honestly, the high quality surrogates. They don't get they know what I like, and I like it's a mutual respect. Yeah, they're good. They're honest, they're thorough, they answer the phone, they respond to emails, they're real. Sometimes you work with agencies, they drive me crazy. And ACRC, they just do a good job. They get me good surrogates. They don't, less drama, and we just move forward. It's great. We got people pregnant, we move on. It's good.
Well, thank you so much, Dr. Norian, for the compliment. And we love working with you as well. We appreciate you, and we're glad we were able to help your cousin. Well, that concludes today's webinar.
本日は、先生ありがとうございました。まさか、いとこさんのお手伝いもしていたということは、今ここで私ども初めて知りました。また先生と一緒に私どもも働くことが、とても安心して、私たちのお客さんをご紹介できるっていうのもあるので、今後ともよろしくお願いいたします。